Okay, welcome to the deep dive. This is where we take your sources, those revision notes you sent in, fantastic stuff, and we just, get right into them. Pulling out the absolute need-to-know info, the high-yield bits, helping you get up to speed fast.
Yeah.
So today, we're tackling a condition that's, well, it's fascinating, definitely. Idiopathic Intracranial Hypertension, or IIH.
That's right. And the name itself gives you clues, doesn't it? Intracranial hypertension, high pressure in the skull.
Right.
But the idiopathic part,
Yeah.
that's the mystery. We don't actually know the cause. But these notes, they give a really good structure for understanding, well, everything else. Who gets it, what it looks like, how to manage it.
Exactly. So think of this as us walking through your notes with you. We'll hit every section you've laid out. Definition, causes, risks, the mechanics, what else it might be.
Differentials, yeah.
Signs, symptoms, investigations, management, and then, the outlook. Prognosis and complications. Really aiming to make those key revision points stick.
Let's do it. Make it clear and memorable.
All right, let's dive in. Definition first. Looking at your notes, what's the absolute core idea for IIH?
Okay, so the core is, it's a neurological condition. You've got elevated pressure inside the skull. But, and this is really crucial, it's right there in the notes. It looks like symptoms you might see with a brain tumor. But there's no actual tumor, no structural abnormality, nothing identifiable causing it on scans or tests.
Right, hence that other name you sometimes see, the one in the notes. Pseudotumour Cerebri.
Exactly. Pseudotumour cerebri, false brain tumor. It really captures that mimicry, doesn't it?
It does. Good memory hook.
Yeah. It flags that worry about something serious structurally, but the investigations come back clear in that sense. And again, idiopathic, cause unknown.
Okay, so high pressure, looks like a tumor, but isn't cause unknown. Got it. But the etiology section in your notes suggests we're not completely in the dark. What factors seem to, crop up alongside IIH?
Yeah, we don't know the why, but we see patterns. The notes point to several things. Hormonal imbalances, obesity is a big one, certain medications, maybe some genetic tendency.
Right, medications. That seems super important for taking a history. Which ones are flagged in the notes?
Absolutely vital for your history taking.
Yeah.
The notes specifically list tetracycline antibiotics, oral contraceptives, steroids, getting too much vitamin A, and lithium. Knowing those is definitely high yield.
That's quite a mix. And what about the ideas for how these things might cause the high pressure, the proposed mechanisms?
Well, the notes mention a few theories. Maybe the body is making too much cerebrospinal fluid, the CSF. Or maybe it's not draining properly, so impaired outflow or absorption. Could be raised pressure in the veins draining the brain, the venous sinuses. Or maybe issues with the brain's cleaning system, the glymphatic pathway, or hormonal changes.
Wow, okay. So lots of possibilities. Do the notes lean towards any particular one?
They do mention that just making too much CSF on its own is probably less likely to be the whole story. It seems the thinking leans more towards, problems with getting rid of the CSF, the absorption or outflow part, or maybe that venous pressure issue. It feels like it's probably a mix of things.
Right, more about fluid dynamics than just production. Okay, so moving from how it might happen to who gets it. Risk factors. Who should really be on your radar for IIH, according to this material?
Okay, the number one risk factor highlighted all over these notes is obesity, especially in women of childbearing age. That link is really, really strong. You absolutely need to remember that.
Okay, obesity, women childbearing age. Got it.
Then, as we said, the medications. And your notes also mention some medical conditions like PCOS, polycystic ovary syndrome.
And pregnancy, is that mentioned?
Yep. Pregnancies listed too. Specifically, the notes mention the first trimester and also the time just after birth, the postpartum period.
Okay. High pressure, unknown cause, strong links to obesity, especially in younger women, certain meds, PCOS, pregnancy. Right. Let's dig into the pathophysiology a bit more. You mentioned impaired CSF dynamics. What's the sort of downstream effect of that? What does the high pressure do?
So the notes are clear. The exact mechanism isn't nailed down. But the leading idea involves that CSF flow being disrupted, either too much made or more likely not enough getting absorbed or flowing out properly. So CSF builds up, pressure goes up.
And the main consequence of that pressure rounds-wise?
The big one is it presses on the optic nerves, right where they leave the eye and go into the brain.
Oh, okay.
That's the critical link. That pressure causes swelling of the optic disc, that's papilledema, and that leads directly to the visual problems people get. Blurring, blind spots. That's why saving vision is the absolute main goal of treatment.
That pressure on the optic nerve sounds like the central problem clinically. So thinking about that presentation, headaches, Vision changes. What else could it be? Your notes list differentials. What do we need to rule out first?
Yeah, it's just so important because the symptoms aren't unique. You have to think about other serious stuff. The notes list actual brain tumors, obviously. Then there's venous sinus thrombosis, a clot in the brain veins, which also causes high pressure.
Right.
Meningitis, hydrocephalus, that's CSF buildup, but usually with big ventricles, unlike IIH and some metabolic disorders too.
So the diagnosis is partly a process of elimination.
Exactly. You're ruling out things with a known cause, tumors, clots, infections, blockages. Getting rid of those possibilities is how you zero in on IIH. You're basically ruling out other reasons for headache, papilledema, and vision issues.
Okay. And quickly on epidemiology, how common is this in the UK, based on the notes?
The notes give a figure around 1 to 2 cases per 100,000 people per year. But like we said, it's much, much more common in obese women of childbearing age. Mostly affects younger adults. And interestingly, the notes say the incidence is going up, linking it back to rising obesity rates.
Wow, that link again, really hammering home that risk factor. Okay, let's get to the clinical presentation. What does someone with IIH actually experience? What are the signs and symptoms we look for?
Right, the classic picture. Your notes list the big ones. Headache is almost always there, usually severe, often described as pulsatile, like a heartbeat in the head.
Okay.
Visual symptoms are really common and, frankly, scary for the patient. Blurred vision, transient visual obscurations where vision just dims or goes black for a few seconds.
Oh.
Sometimes flashes of light, too. Tinnitus is common, often a whooshing sound in time with the pulse. And double vision, diplopia.
And the key sign on examination.
Papilledema. Definitely papilledema. Swelling of the optic disc at the back of the eye. You see it with an ophthalmoscope. It's a direct result of that high pressure on the nerve, usually in both eyes. That's the hallmark sign.
Are there other things mentioned?
Yeah. The notes also list possible cognitive issues like trouble concentrating. They mention tinnitus again, and also problems with smell olfactory dysfunction, though maybe less common. They also detail the headache characteristics, often worse morning or night, worse when straining or coughing. And the visual stuff can include losing peripheral vision gradually or blind spots called scotomas.
Okay, so someone comes in, bad headache, maybe vision changes, maybe that whooshing sound, you suspect IIH. How do you actually investigate and confirm it, according to these notes? What's the workup?
So investigations start with some basic blood tests. Your notes list things like full blood count, ESR, iron studies, maybe checking for autoimmune markers like ANAs, coagulation studies. These are mainly to help rule out those other differential diagnoses we talked about earlier.
Right, looking for inflammation, anemia, clotting.
Exactly. And maybe Lyme screening, if the history fits. Then imaging is absolutely crucial.
CT or MRI?
Either CT or MRI, yeah. Essential to rule out a tumor, a clot, hydrocephalus, any structural cause. And here's that key point again from your notes for revision. In IIH, the ventricles, the fluid spaces in the brain, look normal size or even small.
Ah, okay, not big like in hydrocephalus.
Precisely. Seeing normal or small ventricles with these symptoms really points towards IIH once you've ruled out a mass. That's a high-yield takeaway.
Definitely. What about checking the vision directly?
Visual field testing. Absolutely essential. It measures the impact on vision objectively. Looking for that enlarged blind spot from the papilledema or any shrinking of the peripheral vision. It helps track how bad things are getting.
And the test that actually measures the pressure.
That's the lumbar puncture, the LP. Assuming it's safe to do, an LP lets you measure the opening pressure directly, and your notes give the magic number. Pressure over 250 millimeters of CSF?
Over 250.
Yeah, but, and this is equally important, the CSF fluid itself has to be normal. Normal composition. No extra cells, normal protein, normal glucose. Both things are needed. High pressure A&D, normal fluid. Remember that. 250 millimeters CSF, normal fluid.
Got it. High pressure, normal fluid, normal-ish brain scan, apart from maybe signs of pressure.
Yeah.
Diagnosis made. So what do the notes say about management? What are we trying to achieve?
The goals are pretty clear. 1, relieve the symptoms, especially the headache. 2, prevent vision loss. That's the absolute top priority because it can be permanent. And 3, reduce the intracranial pressure itself.
Okay, and how do we do that? What are the main strategies listed?
Okay, several approaches in the notes. Weight loss. This is presented as the absolute foundation, the mainstay, especially if the BMI is over 30. It's often the single most effective thing long term.
Right, that link to obesity again.
Exactly. Then medications. Acetazolamide is highlighted as being very effective at lowering the pressure. Topiramate is mentioned as another option. It also lowers pressure, plus it can help with migraines, which often overlap, and it might help with weight loss too, as it can suppress appetite.
So those meds are directly trying to ease the pressure on the optic nerves.
Yeah, precisely. Lower the pressure, protect the nerve, stop the vision loss. Managing the headache itself is also important. The notes mention treating it like migraine if it feels like that, and being careful about medication overuse headache.
What if the meds aren't working well enough, or the vision is declining really fast?
Mhm.
Are there more invasive options?
Yes. The notes cover surgical options for those tougher cases. Things like optic nerve sheath fenestration, basically making tiny slits in the nerve covering to let fluid out right there. Or CSF shunting procedures, putting in a tube to drain the CSF somewhere else, like the abdomen. And sometimes venous sinus stenting if there's evidence that a narrowing in the brain veins is the main problem. But the notes emphasize surgery isn't a replacement for weight loss. Those efforts need to continue alongside.
Makes sense. Always back to the fundamentals. Okay, treatment covered. What about the prognosis? What's the long-term outlook according to your notes?
It varies, but generally, if it's caught early and managed properly, the outcome can be good. Early diagnosis and treatment are key for stopping vision loss and controlling symptoms. However, your notes do say it can come back or become a chronic issue needing long-term follow-up for some people.
Did that study mentioned in the notes give any clues about who does better or worse?
Yeah, that retrospective analysis was interesting. It found about two-thirds did well, about a third got clinically worse over time. But things like age, gender, how bad the headache was initially, even the starting pressure or MRI findings, none of those really predicted the outcome in that study.
So what did predict a poorer outcome?
Two things stood out: delaying treatment and having really widespread visual field loss when they were first diagnosed. So basically not getting treated soon enough and having more severe vision damage already.
That really underlines the urgency, doesn't it? Get diagnosed, get treated, especially if vision's badly affected.
Absolutely. And the notes also clearly state IIH doesn't affect how long you live. It doesn't increase mortality.
That's good to know. Finally, complications. We know vision loss is the big one, but what else is listed?
Yeah, permanent irreversible vision loss is the most serious complication if it's missed or undertreated. Beyond that, people can be left with chronic, disabling headaches or that persistent tinnitus, which can really impact their quality of life, lifestyle limitations.
So again, it all comes back to catching it early and managing it well to minimize those risks.
Exactly right. Timely diagnosis, effective management, that's the best way to avoid the worst outcomes.
Wow. Okay, that was a really thorough walkthrough of IIH, all based on your notes. We covered the definition, the mystery cause, the strong risk factors like obesity, how it shows up, the investigations like that LP pressure.
And the management, focusing on weight loss and protecting vision.
Yeah. It really shows how breaking down a complex topic like this, section by section from good notes, can make it much clearer.
Definitely. A structured approach really helps for revision.
It does. And yet, after all that, that central question remains, doesn't it? Why idiopathic? What is that underlying link between weight, hormones, maybe medications, and this specific problem with CSF pressure? That's the big puzzle piece still missing, you know?
An excellent thought to leave things on, something still being actively researched.
Well, thanks so much for sending in the notes for this deep dive. We really hope going through them like this has been helpful for your MSRA revision.
And if you are preparing for your MSRA, you might find more great resources, like these notes perhaps, over at pastthemsra.com.
Yeah, definitely check them out.
And also, don't forget freemsei.com, loads of excellent free revision materials there too.